We're shifting gears, as I mentioned earlier, to really focus on the world of survivorship and its impact. And as you can see from your program, we have outstanding speakers ahead that will take us up to our lunch break. And our chair of this session is a doc I just met, at least live yesterday. We'd had a couple of pre-Zooms, but let me introduce Dr. David Freyer. He directs the Cancer Survivorship Program at Children's Hospital Los Angeles and USC Norris. So he's across town. Maybe they have a helicopter for you. He's the founding co-director of the Southern California Center for Young Adult Cancer Survivorship Research and is the immediate past chair of the Children's Oncology Group, Adolescent and Young Adult. So we call that AYA, for those of you who don't speak this language. Oncology Committee, ran that for quite a while. His clinical care focuses on intersections of cancer survivorship and cancer control, supportive care, and AYA. And he brings to us that perspective. When we think about young people with GI cancer, we keep talking about it starts at around 20. And so the AYA movement is really up to the age of 40 or 39, depending on who's drawing the line. And so this is a heavy overlap with the world of AYA, pediatric oncology, pediatric thinking, and young adults with GI cancer. So we're very honored for him to come open our session and then lead our session. Dr. David Freyer.
Thanks very much, John. Can everybody hear me okay? Thank you. So I'm very excited about this session, actually, to hear my colleagues who are speaking. We did have a chance to interact yesterday, but I look forward to hearing everything that they'll be presenting today. And in fact, I hope that you'll appreciate the interdisciplinary nature of survivorship care. Excuse me, and you'll see that we have three different disciplines represented. I'm going to start by trying to set the context or the big picture of survivorship after early onset cancer, and then each of my colleagues will be speaking about early onset GI cancer specifically and survivorship issues from this population, which I think you'll agree are significant. I actually wanted to begin by discussing this point, which is a little bit subtle, but for those of us who work in the field, it might be worth commenting on, which is what is the distinction between what we call early onset cancer or cancer in adolescents and young adults. So adolescents and young adults are a population that's been identified in the past couple of decades by the NCI as a high priority population. The age is defined as 15 to 39 years of age in North America. In other parts of the world, 15 to 24 years of age. But however you set the bar, the rationale for this is that there are differences in physical maturation, health, the comorbidities that they come into cancer with, psychosocial concerns, the types of cancers that they develop, and also the challenges of cancer care that make them different from younger patients and older patients. So what makes this age population distinctive? There are several things, actually. First of all, it's who the patients are. Understand that in this age group, they're in a challenging life stage, and they're also quite young, and they have a long life trajectory ahead of them. Some have multiple insults, so they're not only young and faced by those challenges, but many of them are of minority status. Many have low socioeconomic status, and then on top of that, you layer cancer onto it, and so they have multiple challenges that other age populations do not. The cancers that they have are a bit different. There's a mix of what we call pediatric cancers, more typical older adult cancers, and they sort of merge in this interval age group. And the biology is different for some of the AYA cancers as well that make the same histological diagnosis different in younger patients versus older patients. Where the patients are treated is different as well. AYA patients tend to be treated in the community rather than at typical academic centers, which means that the type of care that they have access to, clinical trials that they may have access to, and other sorts of support services are different. And then who treats the patients are different as well. You can appreciate that for the age group 15 to 39 years, it takes both pediatric oncologists and medical oncologists working together in a unique way that is not necessary for almost any other group of patients to treat adequately the entire age spectrum. And then finally, we know there's a well-documented low level of participation of AYA patients in cancer clinical trials of all types, which greatly impedes the progress that we can make through that important mechanism of advancing the science. What about early onset cancer? So we've been hearing a lot about early onset cancer, and just in the past 2 to 3 years, there have been a number of papers published, reviews and original papers showing, documenting this increased incidence of cancer in patients who are aged 18 to 49 years at diagnosis. This is a global phenomenon, has been mentioned, and notably involves developed countries. The types of cancers that are being seen are those normally diagnosed historically in older patients, so breast, colorectal, gastric, pancreatic, nasopharyngeal, lung, prostate, and others. And there's been an average annual percent increase in 1 to 2% and more than 2% for some of those cases. With risk factors, we've been hearing about that a little bit today. Smoking, alcohol, obesity, inactivity are thought to play roles, but also pollution, environmental pollution, early life exposures, possibly the gut microbiome, as we've heard so elegantly today, as well as genetics. So there's clearly a relationship between what we call early onset cancer and AYA cancer. And the way that I sort of think about these two in my own mind is that the term early onset cancer works really well when we're referring to the malignancies that these patients get, whereas AYA cancer is useful when we're talking about the patient population, which has a number of many distinctive features, as I've mentioned. So with respect to AYA cancer, this figure here shows by age the number or the incidence of new cancer patients per year, again by decade. And the boxed area shows what the AYA population is. Compared with younger patients, 0 to 14 years of age, cancer in AYA patients is much more common, 8 times more common, in fact. But interestingly, of the total number of new cancer patients, which is almost 2 million, AYA patients constitute only 5%. So this population sort of gets lost. They're not focused on historically by the pediatric oncologists. They are sort of diluted out, if you will, by the many more older patients in medical oncology. And so it's been a very interesting and somewhat overlooked group of patients over the years who are now getting much more attention. The types of cancer that occur in AYA shifts even within that AYA age group of 15 to 39 years of age. There are some, such as those shown here, that are fairly common and sort of are as a proportion are fairly consistent over the age group. In some cases diminish as the patients get older, but there are some where they become a little bit more common, colorectal being one of them, as we get a little bit higher into the AYA age spectrum. The good news is that AYA cancer survival is quite good overall. When we take the patients together in aggregate and look at their 5-year relative survival, they actually have the highest 5-year relative survival of any of the age groups, according to the most recent poll of SEER 22 data, the 5-year aggregate relative survival being 85.8%, which is wonderful news. Not all patients experience that, obviously, and there are pockets of disparities. Patients with advanced stage, specifically metastatic disease, tend to do much less well with almost all cancer types. Also, survival is a function of, unfortunately, race, ethnicity, and some other factors that have negative impacts. Nevertheless, with survival being as high as it is now, recent calculations show that currently, and I think this is probably a minimal estimate, is that there are 2.3 million survivors diagnosed since 1975 now alive after AYA cancer in the United States. And as you can see from the trajectory of that curve, that's a number of patients that is continually growing, and hence the need for survivorship. However, within this group of survivors, there are some important things to be known, and that's, again, where survivorship comes in. In this figure here, published from the MD Anderson Cancer Registry just a few years ago, you can see in this graph that in the blue line, the AYA patients, now these are those who are 5-year survivors. So these are not this overall survival curve here is not from diagnosis. It's actually from 5 years after diagnosis. So these are what we would call long-term survivors. But as you can see, compared with the US population matched over the decades that follow, there's clearly a fall off in survival and a problem with premature mortality. When the investigators looked at this by function of sex, by race, and by age of diagnosis, there were some important and clinically or statistically significant differences noted. And also the effect of some treatments. This curve just added there shows the impact of radiation therapy, where patients who receive radiation therapy have lower survival over time, indicating or suggesting that those are probably late effects that are occurring. So when knowing that our survivors of long-term survivors of AYA cancer have premature mortality, there's been some interest in knowing what the causes of late mortality are. What this study showed was that by 30 years after reaching 5-year survival status, the causes of death due to second malignancies or non-cancer causes actually meets and exceeds and overtakes the causes of primary cancer as a cause of death. So again, things other than the primary cancer overtake recurrence of the primary cancer by 30 years after reaching long-term survivor status. And when that's split out a little bit further, as shown in this top curve here, the light blue line in the middle are non-cancer causes. The black line at the top is recurrence of the primary cancer, and the red line is second malignancy. So you can actually see that in aggregate, non-cancer causes are actually, as time goes on, become more important, and actually in some cases, as shown in these examples here, they actually exceed recurrence of the primary cancer as the main cause of death in patients. We see that in cervical cancer in these examples here, Hodgkin lymphoma, testicular germ cell tumor, thyroid cancer, and in non-Hodgkin lymphoma as well, non-cancer causes as a cause of death become very close to recurrence of the primary cancer. When we drilled down on what those causes were that were non-malignant, so again, these are things other than secondary cancers and things other than recurrence of the primary cancer, we found that the largest proportions were due to cardio-cerebrovascular disease, infections, interestingly enough, and external causes, which would be accidents, trauma, and the like. In addition, pulmonary fibrosis, which I didn't break out here, would be additional examples. So these are essentially lethal examples of what we refer to as late effects, which are the long-term consequences of cancer treatment. And late effects have been defined a number of years ago. I think a very useful definition was any adverse consequence of cancer treatment or that's either physical or psychosocial that develops or persists beyond 5 years from diagnosis. So the thing is, there are many late effects that are not lethal, and those are what survivorship is concerned about as well. Some of them are the lethal ones that were called out in that particular paper, but I would want to emphasize that there are many late effects that are not lethal but are clinically extremely important. Cognitive dysfunction being one of them, so-called chemo brain, hearing loss, endocrinopathies of different types, infertility, important for GI cancers, diarrhea and stool leakage, small contracted bladders after radiation, osteonecrosis, neuropathy, and let's not forget about some of the general side effects like fatigue, chronic pain, and psychosocial impacts. So these are the focus of survivorship care, is to try to impact on those that are lethal and causing premature death, but also those that are seriously diminishing quality of life. So the question is how to best study late effects among survivors of AYA cancer. I think a good paradigm to look at is a study that many of you are probably familiar with called the Childhood Cancer Survivor Study, which is a collaborative multi-institutional, retrospectively ascertained cohort study of children who were less than 21 years of age at diagnosis and surviving 5 or more years. So these, again, by definition, were long-term survivors. This visionary and really transformational study was launched in the mid-1990s, led by Les Robeson, who was the PI for many years, and then succeeded by Greg Armstrong. It involved about 30 institutions in the United States, involves over almost 40,000 participants, so survivors of childhood cancer who were diagnosed between 1979 and 1999, and over 5,000 siblings, providing very useful comparisons. It has a number of core facilities around the country, and really it's been focused on late effects discovery and characterization, identification of risk factors, and development of monitoring guidelines, and more recently predictive models for specific late effect. It would be impossible to overstate how important this cohort study has been, and there have been others like it developed around the world. But it was responsible for this now classic study published back in 2006, which I think for the first time defined the landscape of late effects among childhood cancer survivors. It found that 25 to 30 years after diagnosis, 2/3 of these individuals had at least one late effect, and over 1/3 of individuals had at least one late effect that was severe or life-threatening. The burden of late effects is remarkable in this population, and these data changed the paradigm for how these patients need to be taken care of, to such that pediatric cancer survivorship is now best practice. It's practiced everywhere where childhood cancer patients are taken care of. We don't know that landscape really very well for survivors of AYA cancer, and so what we really do need is a large AYA cohort study to understand the same things that have been studied in pediatric cancer survivors. The challenge is that we don't have that for a variety of reasons. It's unclear whether we'll ever really be able to mount that kind of a study and obtain the kind of funding that's necessary for it. But despite that, there are some efforts now to put together smaller cohorts that are beginning to fill in some of the pieces, perhaps not in quite a comprehensive sort of way across diagnoses, but very valuable nonetheless. I'd like to highlight this particular study that was published from the Kaiser Permanente group in Southern California. And I would focus your attention on the gold boxed graphs at the bottom. These were patients treated for AYA cancer, so with the classic diagnosis, and they were matched 13-1 with cohorts in the same integrated health system. The blue line at the top shows the development of chronic health conditions or late effects compared with their non-cancer comparison. So the first one with any late effect, having more than 2 in the middle panel, and then having more than 2 in the last panel there. You can clearly see there's a statistically significant higher rate of late effects developing in these survivors of AYA cancer with multiple diagnoses. Drilling down on that a little bit, the investigators looked at the incidence rate ratios of a number of late effects compared with their controls. These are incident rate ratios because as AYA patients age, some of them are going to develop certain chronic conditions just as a function of aging. So the incident rate ratio allows a comparison for the patients who were treated for cancer with those who are otherwise maybe developing similar things, but not due to cancer-related causes. And as you can see here, however, in the boxed area, that the incident ratios are significantly higher in the cancer survivors for a number of very important late effects: cardiomyopathy, strokes, premature ovarian failure, hearing loss, renal failure, and avascular necrosis, where the rate ratio was almost 10 times greater. When we looked, the investigators also were able to start to take a look at some of the impacts of specific treatment exposures, called out here 2 of them, cardiomyopathy on the top and hearing loss at the bottom. So for cardiomyopathy, they were able to establish a relationship between anthracycline dose, So cumulative dose over 240 milligrams per meter squared, a significantly higher incident rate ratio of developing cardiomyopathy, and importantly, exposure to trastuzumab or Herceptin, which is commonly used in treating AYA breast cancer patients. Again, a much higher and significant incidence rate ratio. As far as hearing loss is concerned, exposure to cisplatin at high cumulative doses also led to very high incidence rate ratios. And I don't know how many times, one of my other interests is hearing loss, cisplatin-induced hearing loss in children. I don't know how many times I've been told that it's not a problem in survivors of AYA cancer because they're older. And if we don't study it, we won't know. But clearly, it is an issue, and this has been seen in multiple other studies as well. There are other smaller cohort studies that are in progress for AYA patients. I identified 3 of them here. The top one is focused on platinum exposures. The middle is a cohort of females, AYA patients, and the last is a Dutch cohort. These are much smaller than the Children's Cancer Survivors study, but they are definitely steps in the right direction, will provide and are already providing actually very important data. So another question is how best to care for survivors of AYA cancer. One of the tools that's been most helpful, I think, for caring for pediatric cancer survivors has been the development of long-term follow-up guidelines. This is now in its, this says version 5.0 here, and literally within the next couple of weeks, version 6.0 is going to be released. These are updated about every 5 years on the basis of new and evolving data. But the follow-up guidelines provide risk-adapted recommendations for monitoring so that we're neither over-monitoring or under-monitoring patients. There's an international version of this that has been developed synthesizing similar guidelines from around the world called the International Guideline Harmonization Group. And very importantly for survivors of AYA cancer, there is a document that's been published now, and this is in now several editions since the first one as well, from the NCCN, focusing on AYA cancer patients and long-term survivors. And the recommendations that are provided there are in many cases adapted from the COG guidelines, but with an effort to try to make this medically relevant, pertinent, again, not over-testing, but not under-testing for this particular population. So what's needed, I think, for survivors of AYA cancer is developing a population that's appropriate to this age group. The pediatric model is one way of doing it. The typical approach there is that survivors are comprehensively evaluated every year until they reach adulthood. They're typically seen in a specialized survivorship clinic with people who focus on this area. They receive survivorship care plans and have the monitoring that I mentioned, as well as psychosocial support services. With the AYA population, most of us who take care of survivors of this age group are not convinced that the pediatric model is necessarily appropriate for the AYA age group. It's also faces some feasibility challenges due to the much larger number of patients who are seen. But I think there's some coalescence of agreement that all survivors, or most AYA survivors, probably should be evaluated once at least. Certain subsets are probably appropriate for monitoring serially on an annual basis for specific late effects where the risk is known. It's essential for these patients to have access to specialists, both medical and surgical specialists, as well as supportive care specialists in the areas of physical therapy, occupational therapy, and nutrition, just to mention a few. Fertility management is a prominent issue in this age group, as you might expect. And sometimes it's fertility restoration as opposed to fertility preservation, which is more of a focus early on in treatment or prior to treatment. Psychosocial support, as we'll hear a little bit later, is paramount for this age group. And in most cases, the model needs to be adapted to the treatment center. Sometimes these are based in the disease teams where the patients are actually treated, and some of them involve involvement of a primary care provider. There are some publications beginning to appear with experience with applying these sorts of principles to institutions. We need more of these things so that we can actually evaluate best practices and we can be learning from each other. I'd like to just finish by saying a word about the role of genetics in AYA cancer survivorship. There's kind of two ways where genetics come to bear, I think, in this population. One is in pathogenic germline variants in early onset AYA cancer. Studies that have looked at this indicate that somewhere between about 8 and 15% or so overall of AYA cancer patients bear some sort of a germline, a clinically significant germline variant. It varies, by diagnosis clearly. But from a really interesting perspective, we're also interested in the issue of variants that may be associated with the development of certain late effects. Why does one AYA patient who gets anthracycline develop cardiomyopathy, another who doesn't, who gets the same dose of anthracycline does not develop it? And it is not maybe completely unexpected. It's not altogether random. I've listed here just a few for some of the late effects here: cisplatin-induced hearing loss, vincristine-induced neuropathy, anthracycline-induced cardiomyopathy. There are some candidates that have been identified. Doing these studies is extremely difficult. Actually, it's really challenging to validate these, to have phenotyping in large populations, that are reliable. But there are some inroads being made in this. This is not yet being translated into clinical practice. I think we can imagine a world where if we knew which patients were at high risk for developing a particular late effect, the treatment might be tailored around that to reduce the likelihood, or else chemoprotectants would be given, to prevent that late effect. We hope that will be the case for the future, but I thought I would just mention that as something that is pertinent to survivorship as well. So I'm going to go off script here because sometimes I know that's a little bit risky, but I'll take my chances. I hope that you will agree that the issue of survivorship and late effects, the issues that I've mentioned here, really are important for these patients. Doing this work is not easy. Being a patient is not easy. Doing the work is not easy. Taking care of the patients, doing research in this area, it's highly interdisciplinary, I think, as our session will show. And it takes significant resource commitment to be able to pull it off. It is not reimbursed well. I will say that HMOs as a whole are the biggest barrier in my part of the world to AYA patients getting appropriate survivorship care. They don't feel that they need to be in specialized clinics, and they frankly don't see the need, I think, sometimes for the care that these patients need. I think if you were to talk to the patients, however, like this young warrior from our center who was treated for GI colorectal cancer, they would beg to differ with that point of view. And so hopefully through sessions like this, which are calling attention to the survivorship needs and the good work that's being done by many people in this room, we can really move forward and make some headway in this area. So thank you very much, and I'm going to look forward to introducing the next speaker.